pharmacology topic is disease-modifying antirheumatic drugs, or DMARDs for short. As you can probably guess from the name, these drugs work to treat rheumatic conditions, the most common being rheumatoid arthritis. This is a chronic, progressive autoimmune disorder that can cause tenderness, swelling, and pain in the joints, as you can see in this image. Unlike other medications, which can be used for symptomatic relief like steroids or NSAIDs, DMARDs work through different mechanisms to actually slow the underlying disease process. As you can imagine, this won't provide immediate relief, so it will take some time for clients to see benefit after initiation of the drug. Because of this, some may refer to them as the slow-acting drugs. Now remember, this is an autoimmune condition. The body's immune system is attacking itself. So to target this disease process, many DMARDs have immune modulatory activity. Some are immunosuppressive agents, so they reduce the activity of the entire immune system to suppress the disease. Others selectively inhibit enzymes that promote gene expression and subsequent activity of immune cells. So essentially, these drugs help prevent proliferation of immune cells, especially the ones that propagate inflammation. Finally, there are some drugs which inhibit inflammatory cytokines, which are proteins involved in cell signaling. The primary cytokine targeted is tumor necrosis factor, or TNF. As I mentioned before, DMARDs are most commonly used to treat rheumatoid arthritis to reduce joint inflammation and prevent joint damage. You can again see an example of the clinical manifestations of this condition in this image. They can also be used for other autoimmune conditions, including psoriatic arthritis, ankylosing spondylitis, systemic lupus erythematosus, and juvenile idiopathic arthritis. In general, DMARDs can be categorized into two different groups. On the left, you can see the traditional or non-biologic DMARDs. These include methotrexate, sulfasalazine, leflunomide, and hydroxychloroquine. These are the drugs we'll focus on during this video. The other group are the biologic DMARDs, which include some monoclonal antibodies. Examples here include etanercept, infliximab, adalimumab, rituximab, and abatacept. A biologic DMARD may be used in combination with a traditional DMARD, but two biologics should never be used together. So let's review adverse effects related to each of those traditional DMARDs, starting with methotrexate. This is a preferred initial therapy for rheumatoid arthritis, but it is associated with numerous adverse effects affecting almost all the organ systems. In order to suppress the immune system, methotrexate interferes with DNA synthesis and cell replication. This can also affect proliferation of other cells from the bone marrow, which can result in bone marrow suppression. This can lead to life-threatening myelosuppression, including anemia, leukopenia, thrombocytopenia, and pancytopenia. Methotrexate also interferes with rapidly dividing epithelial cells, such as those in the GI tract. This can lead to adverse GI effects, including nausea, vomiting, diarrhea, and stomatitis, which is inflammation of the mucous membranes in the mouth, leading to pain and ulcers. Because methotrexate can accumulate in liver cells due to impaired folate cell transporters, liver damage or hepatotoxicity can occur. This can range in severity from asymptomatic elevations in liver enzymes all the way to hepatic fibrosis and cirrhosis. Severe fetal toxicity, including fetal death, can occur with use of methotrexate. Therefore, it's contraindicated for use during pregnancy for rheumatic conditions. Methotrexate can cause acute kidney injury by causing direct tubular damage, as well as by accumulating in renal tubules and forming crystals leading to renal obstruction. Resulting nephrotoxicity can then reduce elimination of methotrexate, which will further exacerbate all adverse effects. Finally, pulmonary toxicity, including interstitial pneumonitis, has been reported with low-dose methotrexate. When methotrexate is used as a DMARD, it should only be administered once weekly. It can also be used for chemotherapy, for which it will be given at higher doses more often, but this should never be the case when used for treatment of autoimmune conditions. As part of its mechanism, methotrexate inhibits dihydrofolate reductase, which can lead to folate deficiency. Therefore, folic acid supplementation may be required, which will also help reduce hematologic, GI, and hepatic adverse effects. Because of the risk of myelosuppression and hepatotoxicity, a CBC and liver function test should be routinely monitored. Clients of childbearing potential should employ an effective contraception plan due to the teratogenicity of methotrexate. Finally, methotrexate can be hazardous to those handling the drug, so gloves should always be worn when handling the tablets or injections. Next, let's review the adverse effects of hydroxychloroquine. You may have seen this medication used as an antimalarial agent, but has also shown benefit in some rheumatic conditions due to its immunomodulatory properties. One of the biggest risks associated with this drug is retinal toxicity. Clients can develop dose-related vision changes and even irreversible retinopathy, usually with long-term use. Dermatological changes can also occur. This can include development of a rash, pigment changes in the skin and hair, and photosensitivity. Some clients may also experience neuromuscular effects related to hydroxychloroquine, such as myopathy and neuropathy. And finally, although rare, there have been reported cases of developing restrictive or diastolic cardiomyopathy with long-term use. Additionally, prolongation of the QT interval and subsequent ventricular arrhythmias can also occur. Any visual changes should be reported to the healthcare provider immediately, as intervention may be required to prevent irreversible damage. Additionally, routine ophthalmologic exams should be performed to monitor for any vision-related damage that may occur prior to symptom development. Muscle weakness, which may occur due to neuromuscular adverse effects, should also be reported to the provider. And finally, the client should be taught to avoid spending prolonged time outdoors to limit sun exposure due to the risk of photosensitivity. Next, we have sulfasalazine. This is an aminosalicylate with immune modulatory properties that's typically for inflammatory bowel disease, but it may also help treat rheumatoid arthritis. This drug can cause nonspecific GI symptoms, including nausea and diarrhea. Hematologic effects have also been associated with this drug, including anemia, leukopenia, thrombocytopenia, hemolytic anemia, and agranulocytosis, which can be life-threatening. Because this drug contains a sulfa moiety in its chemical structure, clients with a sulfa allergy are at risk for a hypersensitivity reaction. In addition to this, all clients are at risk for experiencing a delayed hypersensitivity reaction, resulting in fever, rash, and multi-organ damage. Although rare, hepatotoxicity leading to hepatic failure can also occur. Finally, this drug may cause a yellow-orange discoloration of the skin and urine, but this is harmless. Because of the risk of cross-reactivity in clients with a sulfa allergy, presence of this allergy should be checked before giving this drug. Any signs of infection or unusual bleeding or bruising should be reported to the provider, as this may indicate presence of a hematologic adverse effect. Skin rashes, which may indicate a hypersensitivity reaction, and jaundice, which may indicate liver damage, should also be reported immediately. And finally, clients should be informed that they may see that yellow-orange discoloration of skin and urine, just so they're aware. Something like that can be alarming if you aren't expecting it. Last but not least, we have leflunomide. Similar to methotrexate, leflunomide can cause teratogenic effects and therefore is contraindicated during pregnancy. Pregnancy must be excluded before starting this drug. GI symptoms may occur, including nausea and diarrhea, and the latter can occur early after initiation, or it can have a delayed onset. Abdominal pain can also occur. Leflunomide alone can cause hematologic toxicity, including leukopenia, anemia, thrombocytopenia, and even pancytopenia. But this risk is higher when used in combination with other immunosuppressive agents. Because of its immunomodulatory effects, immunosuppression can occur. This can increase the client's risk for severe infections, including sepsis, opportunistic infections, and tuberculosis. Leflunomide can also cause a range of dermatologic reactions, including alopecia and a rash, as well as more severe presentations such as Stevens-Johnson syndrome. Finally, dose-related hepatotoxicity can occur, which can range in severity from asymptomatic elevations in liver function tests all the way to fatal hepatic failure. Appropriate contraception should always be used when taking this drug because of the risk of harmful effects on a fetus. Similar to sulfasalazine, any signs of infection, bruising, or bleeding should be reported to the healthcare provider, as this may indicate underlying hematologic toxicity. Because of the risk of progression and severity, any rash should be reported to the healthcare provider for evaluation. Clients should be taught that they may expect some hair loss while taking this drug. And finally, jaundice should be monitored for, as this may indicate liver damage. All right, let's wrap up by reiterating a few of those nursing interventions. Because of the risk of hepatotoxicity with many of these agents, any signs or symptoms suggesting this, such as abdominal pain, clay-colored stool, or jaundice of the skin or sclera, and you can see an example of this here, should be reported to the provider immediately. Additionally, liver function tests will need to be routinely monitored. Because these drugs affect the immune system, precautions should be taken to reduce risk of infection, such as avoiding large crowds. Live vaccines should also be avoided, as these clients are immunocompromised to some degree. Both methotrexate and leflunomide, which are teratogenic, should also be avoided in breastfeeding mothers due to the risk of adverse effects for the infant. As I mentioned before, sulfasalazine contains a sulfa moiety, therefore should be avoided in clients with a documented sulfa allergy. Because hydroxychloroquine is associated with a risk of retinal toxicity, any changes in vision should be immediately reported to the provider. Finally, because of the immunomodulatory actions, there is a risk of worsening or reactivating some illnesses with use of many of these drugs, especially leflunomide. Because of this, caution should be used when giving this drug to clients with a history of new, recurrent, chronic, or latent infections, such as an active herpes infection, active or latent tuberculosis, and acute or chronic hepatitis.